Okay, we're back. And so moving along with the cholesterol screening, detection, evaluation, and treatment. So how do we even know somebody has high cholesterol? Well, it's basically simply from a blood draw. This is not any huge diagnostic procedure. They're recommending now every 5 years for an adult over age of 20. And now, because of what's happened with our diabetic type 2 epidemic proportions in the United States, they're now saying for children between the ages of 9 to 11 and a basic screening. And now they've dropped it even back for families that are known for high cholesterol in children between the ages of 2 and 8. Isn't that crazy? Just crazy. But that's okay. Knowledge is powerful. Though the total cholesterol is going to be all of it together, and we're not going to be too concerned with that right now. Let's break it down. Let's look at our heavenly cholesterol, and that is the one that we know is going to protect us. So we want that to be a little bit higher. So if it's less than 40, they say that's low to undesirable. Below 40 is low. It increases the heart disease risk. From 40 to 59 is normal, but again, the higher the better. We want it higher than 40. Remember, this is the one that's going to take that cholesterol back to the liver and get rid of it. And then 60, okay, so less than 40 is not good. 40 to 59 is normal, again, but the higher the better. If you're at 60, it says it's the best level. It offers protection against heart disease. So that's what we want with that HDL. The LDL is a different story. We want that under 100. If it's greater than 100, it's no less than 100. I'm sorry. I'm looking at the thing the wrong way. I'm like, no, we don't want a greater 100. If it's less than 100, it is the most desirable. And we hear of people that are in, over 200, over 300. And that is, they are headed for heart disease. And then our triglycerides, we know what they are. They're not really sure how. So I'm not even going to give you a level with that. They're not sure how that interacts, except that we know that it does adhere to the lipoproteins, and it does add to it. But I want to talk a little bit about coronary artery disease or heart disease. They look at anybody with diabetes, especially females, inactivity, obesity, which increases the risk of diabetes and hypertension, and high cholesterol. Smoking dramatically drops within 1 year of quitting with cholesterol levels. Stress, any systolic blood pressure greater than 119 or diastolic pressure greater than 79 over time. Hormonal contraception use they're looking at. Age older than 40, family history of coronary artery disease, male, white male, and high resting heart rate. Signs and symptoms, angina is the classic sign of coronary artery disease, and that's chest pain, which we know results from a reduced supply of oxygen to the myocardium. It may be described as burning, squeezing, or tightness in the chest that may radiate to the left arm or shoulder blade, neck, or jaw. Females may just experience fatigue and shortness of breath with none of the obvious symptoms. They say that females and males present differently with a heart attack. So sometimes they'll say with the females they may have pain in their back, their upper back, but they don't present like a male as far as the classic symptoms of the burning, squeezing, or tightness in the chest and the radiation to the left arm. Females don't experience that. Black and Hispanic cultures, those females as well. These patients may also have cool extremities. They may just have nausea, vomiting, and diaphoresis. So you could think it was anything. Diagnosis usually, once they get them in and they can feel that there might be a rhythm that's not right in the pulse, they'll do an EKG. That's what needs to be done. It'll show changes if there's enough ischemia. Treatment, we want to give them nitrates. We want to give them nitrates to reduce myocardial oxygen deprivation. The nitrate's just going to open that wide vessel. So, and we'll go on. We'll talk about more of the treatment and prevention in the other lecture with just pathophysiology. So, treatment of high LDL cholesterol. We want therapeutic life changes, weight control with a low-fat diet. We've kind of gotten that from what it does. Encourage patient to eat plenty of raw vegetables and fruit. and brand. We've been talking about that since day one here. The American Cancer Society wants you to have 5 to 6 vegetables a day. It actually would work for the Heart Association also. And look at this: drink 2,000 cc's of fluid when on anti-lipemics. It actually kind of slows down the GI tract, and they have problems with constipation. So another reason to drink the water. Exercise, 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 and of course smoking cessation with weight control, some type of a weight control program. And then let's look at our statins. These are, first of all, contraindicated for pregnancy. They are considered risk category X. The risk to the fetus way, way, way outweighs the benefits to treatment. But these are the first line drug therapy for hypercholesterolemia are statins. So you can see they're also referred to as HMG, CoA, reductase inhibitors. That all has to do with that triglyceride, HDL, not HDL, I'm sorry, LDL, turning the chemical into, or the fat, I should say, into the lipoprotein through the apolipoprotein. And so it's going to stop that. It's going to inhibit that. And here you could, all the statins, atorvastatin, Lipitor, Simvastatin, Zocor, and they are the most effective drugs that we have today for lowering that LDL, or that lousy cholesterol. And look at, in the studies, a reduction of LDL cholesterol by 30 to 40%, and it elevates the HDL, which is the heavenly one, right? We want that elevated. Non-lipid beneficial cardiovascular actions. It reduces the risk of cardiovascular events, and that would be strokes. So it helps with that too. And increases bone formation. I haven't been able to figure out how it does that, but that's what it says. Therapeutic uses, again, hypercholesterolemia. All that means is you've got high cholesterol in the blood of the bad cholesterol. Primary and secondary prevention of our cardiovascular events. And it's also for diabetes, because we know fats, after a while, are going to be turned into simple sugars, and there you have the risk for diabetes and glutting up the circulation with high cholesterol. Adverse effects, we do have effects. Headaches, rash. The GI disturbances are the ones that are common for the constipation, because it's going to slow everything down. Myopathy for muscles is rare, and hepatotoxicity, liver toxicity is rare. And that's interesting, because we know with the cholesterol, its formation, it's coming out of the liver and going back into the liver. So that's why these are great drugs. As we're going to see with some of these other ones, it can cause liver problems, such as niacin. So nicotinic acid, or niacin, also known as a vitamin, we know, it reduces LDL and triglyceride levels. It increases HDL levels better than any other drug. So what does that tell you? That tells you that they'll probably, knowing that the statins are the best drug of lowering LDL, and we want that HDL elevated, right? Could you see them putting niacin with the statins? Of course, because then we have the best LDL lowering drug, which is the statin, and the best HDL elevating drug, which is niacin. Decreases the production of the very low density lipoproteins. Therapeutic uses, lowering triglyceride levels, and again, elevating that HDL cholesterol. Adverse effects, and these does cause liver problems and hyperglycemia, which we have trouble with diabetics already. So we have to be very careful with these. Our bile acid binding resins, questrin, cholestid, reduces LDL, increases VLDL in some patients. Let's see. This one can also have belching, bloating, headache, ringing in the ears, bleeding, and a burnt odor to urine. So these ones aren't used as much as the other ones. Fibrates are the most effective drugs for lowering the triglyceride levels, important in forming our lipoproteins. And you can see also that decreases triglycerides, lowers the VLDL, raises HDL, reduces high levels of plasma triglycerides. Adverse effects, most of them have some myopathies and liver, except for the statins, and those are the ones that we're going to use. GI disturbances, again, are going to be nausea and vomiting and some constipation. And then Zetia, a mechanism of action and impact on plasma lipids. This is another one they combined with statin or by itself. It's also known as ezetrol, Ezetrol, goes by Zetia and ezetrol, which you can kind of see the Eze probably comes from that generic word, ezetimibe. Inhibits cholesterol absorption or blocks cholesterol absorption in the small intestine. That's what this one does. So again, it's going to cause some problems in the GI tract. But look what it does. It reduces total cholesterol, LDL, and apolipoprotein B, which earlier I said had been a genetic link to this stuff. Rhabdomyolysis, though, is nothing to mess around with. That is a breakdown of muscle fibers that can, if it's broken down enough, it goes in and clogs up the kidney. It can cause kidney problems. So this one they have to watch very, very closely. And if we know it's going to hurt the kidney through rhabdomyolysis and they are getting this drug, would they be looking at the BUN and creatinine while they're giving it? Well, they should be. And the platelets. So this one, good drug for reducing LDL, but it causes, there's a lot of adverse effects. Again, the statins are safer. Other drugs used to alter plasma lipid protein. And this is what I mean when I'm saying we're doing combinations. We've got our statin there that's going to lower the LDL and HDL for lovastatin with niacin. We're going to reduce LDL and triglycerides and elevate HDL. And you can kind of see here's another statin with the Zetia or ezetrol, pravastatin, and aspirin, astervastatin, another statin, and our amlodipine. Fish oil, plant stenol, and sterile esters they'll use. Estrogen and cholesterol. Estrogen, it's not used too much anymore, but from postmenopausal women, they've done studies, it decreases LDL by 15 to 25%. Well, if you go back and look at the statins, it's higher for them. Increases HDL by 10 to 15%. But how often have I told you don't take the estrogen? It can cause GYN cancers. And cancers in men also, by the way. But they do still use it. I would refuse it if it was me. Colistin is a dietary supplement that can lower cholesterol. And colistin actually has lovastatin in it. But we're lacking information on both colistin and estrogen as to adverse effects, except for we know what estrogen can do. So if it was me, I would stay with one of the drug combinations. And let's see. I think that ends this. Yep, I think that's it for our plasma lipid lowering levels. Okay, I'll talk to you next time.